Thank you. And we're just going to cover a few issues, but we'd like this to be a conversation not only between myself and Raja, but with you. So we're going to break this up into a couple sections. So we learn a little bit about what's happening in Thailand and then what the implications have been for training, particularly in issues around work hours and work-life balance. So we're going to use this as kind of a framing slide. And I'm going to turn it over to Raja to talk about what's kind of happened in Thailand as a system, and then we'll move on to talking about what the impact has been. So, Professor, over to you.
Thank you, Eric. Good morning. It's an honor for me here, to be here and get invitation. Thailand is the country of about 68 million populations. Its gross national income is around $6,000 per capita. And also the total healthcare expenditure of the country is around 4.6% of its GDP. This is in sharp contrast to which the United States is spending at the moment, which is around 16 to 18% of its GDP. But Thailand, even though it's not a rich country, we are capable of offering our citizens universal health coverage. Right now, there's about 185 countries in the world. According to WHO, only about 60 countries can offer its citizens with universal health coverage. And universal health coverage in Thailand doesn't come at once. It comes in a consecutive manner. Take a look at the slides. In 1960, this is the first healthcare scheme coming out, which was a civil servant medical benefits scheme. In the 1960s, it covered the government employees and dependents and retirees, cover about 8% of population, and is funded totally by the government. Later on in the 1990s, social health scheme came out, which now cover those in private sectors, employees, about 17% of population covered, and the funding is through three parties: the government, the employer, and employees themselves. And then in the year 2001, universal coverage scheme came out to cover the rest of the population, which is about 75% of the population, and it is totally funded by the government. So this is the way we have our universal health coverage starting for almost 20 years now in Thailand. And you may be wondering why a country like Thailand, which is not a rich country, can afford to have universal coverage to its people. I think the answer comes in two major factors. The first one is that we have a very extensive infrastructure of healthcare. For governance, the country is divided into 77 provinces, and each province has about 7 to 10 districts, and in each district we subdivide into the smaller areas of governance, which is called sub-district. Sub-districts covered about 10 to 15 villages, about 10,000 to 1,500 people. So in each sub-district level, we have one primary care center. In each district, which is about 774 districts all over the country, we have one district hospital, which is a secondary care staffed by medical doctors. And then at the provincial hospital, we have about 83 hospitals in the 77 province, which means that one province may have more than one tertiary care hospital. And then we have a regional, so-called regional hospital, which provide quaternary care for the complicated cases. So this is one factor. We have a quite extensive hierarchy of healthcare infrastructures. And the second factor, I think, is our human workforce in health. We can produce our own medical doctors, our own nurses, dentists, pharmacists, you name it, we have them trained inside the countries. And also the subspecialty training of many areas also can be trained in Thailand. So I think these two factors enable this country to afford the healthcare for our citizens.
Thanks, Raja. One of the things that really struck me about this slide, in the 1990s, you're covering about 11 million. And in a very short period of time, you literally almost quintuple the amount of coverage. And so, I think the question that you and I talked about, and I think the group have been interested in hearing about, is what was the impact for both the patients, but also for the workforce? And so, I was struck by this slide you provided about kind of the differences in satisfaction between the kind of patients who, in your population, who clearly, love having universal health care. But it sounds like for the healthcare providers, this has been a bit of a challenge. Can you say what it's been like to have that kind of dramatic increase in coverage and what the impact has been on your healthcare providers across Thailand?
Well, yes, this slide tells you the story very well. That if you look at the patient's satisfaction of universal health coverage, it ranges 10 years back. It ranges from 83.91 up until right now. Last year is about 95.66, which is excellent satisfaction by the people of Thailand. This is no wonder, because once universal health coverage is in place, people get ready access for health care more than before. So the numbers of patients visiting hospital has increased about twofold. And also, if you look at the benefit package of universal health coverage in this country, we have a basic primary care package, vaccination for newborns, every kind, and also for complicated disease. We even have the package for cardiac surgery, valvular disease replacement, balloon angiography. We have stroke fast track, myocardial infarction fast track in operation in every district hospital in the country. And in specific cases, we also provide them with liver transplant. For example, in the infant born with biliary atresia, they got liver transplant or bone marrow transplant in some cases, and also renal dialysis, peritoneal dialysis, and renal replacement therapy. So the benefit package is quite good. So I'm not wonder why the patient's satisfactory is quite high, and it reflects also if in the metrics of our healthcare, that the indicators of healthcare, specific indicator like 5 years mortality rate of the infant or maternal mortality has came down, equivalent to the level observed in the developed countries like the OECD countries, we have the longevity of both men and women, and also, most importantly, one of the most important metrics is that the impoverishment from catastrophic illness has came down dramatically. So it's no wondering why the patient is satisfied with the program. But if you look at the healthcare providers' satisfaction in their job, there's about 30 points difference, 34-point gaps. And I'm not surprised either in this observation, because you can imagine how stressful, how work that has increased after the initiation of the health coverage has affected them. So I think they're working in quite work quite hard, and especially we have very extensive healthcare infrastructure that is easily for the patients to come to the medical facilities.
So right, that's a wonderful context. We kind of wanted to set that up to really now talk a little bit about what the impact has been around work hours. And before we kind of take a look at a couple of stats that you provided, can you just tell the group quickly about your kind of medical education system that we talked about, that they graduate from medical school and then they spend 3 years kind of out in the community as, quote, interns before they go to specialty training. Can you just say a little bit about that system?
But sure. We have about 19 medical schools in the country. We can produce about 2,500 medical doctors per year. If you look at our medical doctors' numbers, it's still not sufficient because we aim for the whole country to have the ratio of 1 medical doctor per 1,500 population. But right now we achieve about 1 to about 2,200. So we need to produce more medical doctors. And the reason that we can provide health care in many different levels, as I've shown you before, is that we have a program which is mandatory for the newly graduate medical students, that they have to serve for 3 years in the rural areas because the government paid for their education. And then they have to serve for 3 years. The first year we can call it intern. They got supervised by the staff members in the tertiary care hospital, mostly around the countries. And then 2 more years, they have to work in the rural hospitals, like district hospitals, which has different capacities of beds, numbers. So 2 more years. And then after 3 years, then they are eligible to do further training. They can now become residents in many subspecialties or specialties in the university hospital. So we have a workforce of the interns and residents, if you may call them, for another 2 more years in the rural areas, taking care of the patients in the rural areas.
So I was fascinated. If you turn to page 6, I'm just going to show you kind of our last 2 slides here to kind of trigger a conversation, then open it up. But this gives you a sense, though, of how hard these folks are working. So this just gives you an idea of how often they're on duty. And it turns out, anywhere from 34 to 73% of the interns are on duties more than 17 times a month. Thanks, Raja. Okay. These are the work hours per week. And if you read the x-axis, yes, that is, 101 to 120. And you can see that 54 to 61% of interns often work 100 hours a week. And so, Raja, I know that you've been involved as one of the leaders in your country in thinking about work hours. And so I wonder if you might reflect on some of the challenges around, the work hours and kind of where do you see things headed, and then we'll open it up to the group for a conversation. So, Raja.
Right. This is the fact that the data that I showed you. And we don't have much data. This is the data that dated back since 2012 that we have. But I don't think that things has changed. That interns and residents that are now working in the rural hospitals, they work quite hard. But when they enter training, formal trainings, then their work burden has decreased during their trainings because the workload is not as much as when they work in the rural areas. So this is the fact that we are facing. And if you ask me what should be the solution for this situation to alleviate this situation, I think there should be some transformation of the way we look at health. First, I'll tell you that most of the patients who come to visit the clinic as hospital, I think probably some majority of them do not have to come to the hospital at all, because they don't get that sick that much, or they have very minor problems. Also, at an emergency room, you look at the emergency room in every tertiary care hospital, quaternary care hospital, 80% of them shouldn't have come to the emergency room in the first place, because they don't have that urgent situation. So I think what we should do is that the first, we should to focus on health promotion. How can we keep our population healthy, abstain from things that can affect negatively their health, smoking, increasing exercise lifestyle modification for promote health. This is the first thing. And secondly, I think we need to strengthen our primary care. We need to have a strong procedures or strong policy for those primary care centers or district health hospitals to work. And we should support them with more resources for them to get stronger for primary care. And especially we're still in need of family care physician or generalist, because right now there are more specialists than generalists in Thailand. We need more family physician. And this fact has underscored in our new constitution. This is very interesting. You may know that Thailand is now under the military rules, and the draft of the new constitution has been taken and has finished already. So the constitution has the one article in the constitution stated that the country should have enough primary care physicians, appropriate numbers. So it's in the constitution at the moment. The other things that I think we should go forward is to promote palliative care, because right now our country is considered the aging population already, and you know aging population comes along with chronic diseases, non-communicable diseases like cancer, heart diseases, which is very costly. And at one point in time, they got to be terminally ill. So we need to have a good care, proper care, cost-effective care for those chronically ill patients. And I think palliative care is a solution. And also, right now, the people in Thailand, when they're going to die, majority of them die in the hospital. So the paradigm must be shifted, that instead of dying in the hospital, the patients should die at home or in hospice. Hospice is a new concept in our country also. We are now initiating, establishing new hospice services in the country. So a few things that I think that we have to change and move things forward in order to alleviate these congested situations in the clinics, which are demanding for the higher working hour of our residents and interns.
One of the things I took away from our conversation, Raj, is that no matter where we are around the world, there's more that binds us than separates us. You know, everything you just talked about, you could have that conversation, I think, in almost any country that I've certainly been in over the last couple of years. So I think there's a lot we can learn from each other, which is, I think what's wonderful about your talk today is that's the purpose of it's a global forum. It's a reason it's called that. Before I turn it up to the audience, I want to ask you one more question. As you reflect on the last day and thinking in terms of systems, using a systems lens and design thinking for wellness, was there anything that struck you around the last day in the context of what you're trying to accomplish right now in Thailand?
I think we got to the organization structures to change. We got to have some change in the organization. for alleviating the stress of our workforce also. At the Ministry of Public Health, we have done something already. For example, right now we have primary focus on primary health care, strengthening primary health care, and also while I was the Minister of Public Health, I issued a policy that every hospital in the country must have the palliative care program. So now it's on, and it's on the process and catching up. And also at the Ministry of Public Health, they also have the strategies for human workforce, that they try to focus human workforce as one of the major strategies to drive the ministry forward. And you can take a look at the details that I provided in the slides. And but one thing is that is happening is that the Medical Council of Thailand, which oversees the ethics or well-being, governing of the medical doctors in this country, have appreciate the fact of the hard working hours of the residents and interns, and they have issued an announcement just last October that the intern shouldn't be on duty for more than 40 hours a week, which is so much different from what is now. And they shouldn't work more than 16 hours in the emergency room uninterrupted. And in addition, those physicians who age more than 55 should be abstained from duty work. This is an announcement, not directive. So they can comply or they cannot comply. It's up to them, up to the context of their situation. But at least I think that the highest governing body of the country has concern of the facts that we had. This is the first step that we heading on. So if this is the first one, then other action plans may come along to help alleviate the situations. And at the Ministry of Public Health, I think that's one of the things that can help these interns, even though they work so hard for 3 years. They know that they don't have to work this hard throughout their life, because after 3 years, they are eligible to go for training, and new batch of interns coming every year. So I think this is at least, kind of some, they know that their lives is going to be like this. They cannot tolerate working like this for so long, I think. And also, at the Ministry of Public Health, we gave them a financial incentive also. If you look at the details, I gave you the details. They have basic salary, but in addition to basic salary, they have additional fees for on duties or for fee for service for doing surgeries, or the compensation for rural areas or dangerous areas, or if they don't do private practice, they have compensation, some amount of compensation. And if they reside long enough in the certain time duration in the rural areas for 5 years, 10 years, 15 years, then they got increasing amount of compensation. So one intern, for example, I have an intern. My son is now an intern at the rural areas in the northeastern part of the country, and his basic salary is about only 25% of what the total take home he got.
I kind of like that over 55 role. I think I might have to move to Thailand. We have about 7 minutes for questions or reflections. Anybody? Yeah, Patricia.
I wondered if, can you hear me?
Yeah, go ahead. I can
Okay.
repeat it.
All All right. Just one point around interprofessional. I've had the honor of working with the nursing schools at Chulalongkorn, at Mahidol, and the outreach to Phuket and Pattaya and Chiang Mai. And for everybody here to know, and I believe it was your queen that was a nurse that wanted to have doctoral nurses in the schools of nursing so that they could move to some form of advanced practice nursing. And I know that there were lots of challenges, so my experience with Thailand is a little bit former, but I wondered if you would speak to, because the same thing was true there in terms of support for the education, and they sent a lot of the nurses to the United States to different schools where we ended up getting them doctorates so that they could have advanced practice and master's programs in the schools of nursing. And so I wondered if you'd speak a little bit, because I know they were working on trying to get nursing into primary care. And would you just kind of update and say how the interprofessional piece of that is working?
Yes, first of all, let me correct you a little bit. The Queen of Thailand is not a nurse herself, but the former mother of the former king, King Bhumibol, former of the former King Bhumibol, Rama IX or King Bhumibol of Thailand, was a nurse. And she graduated from Simmons College in Boston. And at that time, the father of the former king, King Bhumibol, Prince Mahidol, which the university I once have been president, Prince Mahidol of Mahidol University. Prince Mahidol is the king's father. He was the medical student at Harvard University at that time. So when he came back to Thailand, then he started to build up the medical trainings as well as nurse trainings, and he got help from Rockefeller Foundation to lay the foundation for modernize the medical curriculum in the countries. So that's why our human resource in health is quite strong. We are in debt to Prince Mahidol a lot, and we honor the university under his name, Mahidol University. And right now, many healthcare professions has become very strong in Thailand, especially nursing professions. We can produce our own master degree or PhD or subspecialty in nursing care, many things like primary care nurses, community nursing, or advanced nurse practitioners. Those are the things that have added much value to our healthcare system.
I think we have time for one more question. Yeah, thanks. Do I got it? Is that okay? So we got one?
Yes.
Awesome. Please, we'll go to table 8.
So thank you very much for your presentation. I really appreciate it. I've had the honor at attending the Prince Mahidol conferences and seeing the workforce, and also what the Thailand government has done to advance universal health coverage. My question is particularly about the workforce in the larger picture. The HRH strategy for 2030 that's come out of the World Health Organization and the Sustainable Development Goals both look at targets for every country to have our dependency on foreign trained nurses and physicians by 2030, to reduce the shortages we have. And based on the numbers that you have both for doctors and nurses, I'm wondering what the plan is in terms of increasing the production or increasing the numbers of schools. Here in the United States, we're not adequately producing and we're not adequately retaining. So globally, that winds up that by 2030, we face a global shortage of a minimum of 18 million healthcare professionals, probably 40 million given the increasing demand. So we all have a part in contributing to doing that. We're not doing a very good job necessarily here in increasing our numbers of medical and nursing schools. So could you comment and give us some advice about what you would like to see happen?
Let me introduce you to one innovations regarding medical doctor productions in our country. About 20 years ago, we have embarked on the innovation, which is the cooperation between the Ministry of Education, the university, and Ministry of Public Health, who has the hospitals in their infrastructures. So the students recruited from the rural areas. These students provided opportunity to study medicine. If they were to compete with other students in the whole country, they wouldn't have much chance because it's very competitive, highly competitive. But we have a special quota for those who living in those certain areas. And the universities in the rural areas provide them with basic science trainings for 3 years. And after 3 years, then they study clinical medicine in the tertiary care hospital of the Ministry of Public Health. It's been going on for 30 years already, 20 years already. This way we can use existing resource to the fullest. We don't need to produce or set up more basic science departments because we can use the basic science department in the existing university already, and we don't need to build the new hospitals, teaching hospital, but we use the hospitals of Ministry of Public Health. So around 20 years has passed already, and now I can say that about 50% of our medical graduates came from this program, 50%, which is about 1,000 something numbers. And they have two objectives of this program. The first one is to increase the numbers of the doctors, and they have achieved that already. Second objective, they need to see that these doctors who are recruited from rural areas stay in the rural areas. And 10 years back, they have a data now just come out that 80% of them are staying in the rural area, which is quite good. So at least we have reached our objective, and the program is still going strong at the moment. Yeah.
I think that's a great place to end. Thank you so much for sharing this morning. Appreciate it.